Now, I got a couple more here that I will. Now, is that the one I want? Yeah, there we go. This is pretty much what it says it is. If you look at the components of health spending, and you look at what's been happening relative to inflation and to population, you see, yeah, it's climbing. There's no doubt about it. We went through a crunch in the 90s, and it's now going back up. But if you look at it relative to GDP, there's nothing very exciting going on. You can see pharmaceuticals tearing up the place. Okay. Now, if you look at provincial government spending, total health spending, you look at Medicare spending, same story. It's climbing. There's no doubt about it. That Wildavsky was not wrong. There are going to need to be constraints on the growth. There are going to need to be solutions, and they're going to have to be public ones. But again, if you do it relative to GDP, you can see that the Medicare component is just not doing anything terribly exciting. So what it brings us back to, I guess, out of all of this, is to say that a lot of attention has been misdirected onto what's been happening to healthcare expenditures relative to provincial government expenditures, this sort of wild talk about how it's chewing up the whole budget. And that arises from A, failure to recognize that budgets have two sides to them, failure to think about revenues rather than expenditures, seeing what's happening to healthcare expenditures relative to revenues. That's a sort of a fundamental error in failure to think about what budgets do. And secondarily, to, I think, lose track of the fact that cost containment is always and everywhere a problem in every healthcare system, and it's something that has to be done. It has to be done thoughtfully. It is going to be difficult because it is going to wind up hitting people's incomes. Shoppers Drug Mart is our leading example, but they're also our leading example of the fact that it can be done. And it will be unpleasant for some. Some of the stuff in the Toronto Dominion report is not bad. They're saying we need to work out different ways of reimbursing hospitals to try to maintain standards and lower cost. I did my thesis on that in 1969 at Harvard. Came up with some ideas. Some were none really were introduced. The most effective mechanism we know for doing this in Canada has been the budget cuts of the early and mid-90s. By simply, just as Wildavsky said, by simply taking away money from hospitals, we forced them to think. There is Sir Ernest Rutherford, the physicist, famously said in his lab in McGill back in the 20s, he called his staff together and he said, "Gentlemen, we're out of money. We shall have to think." And one of the things hospitals in Canada thought about in the 90s is they thought about the fact that they'd known for the best part of 20 or 30 years that a lot of the people who were there as inpatients didn't need to be. And all of a sudden, all the ideas that have been floating around for years about how to look after people on a day basis rather than keeping them in for several nights were suddenly introduced. And hospital costs went down, and patients went home earlier. And speaking as a highly experienced patient, I can tell you that's a great idea. And most doctors will tell you the same thing, that if you can get them home, that's the best place to be. But it was 20 years of inertia before the research on this that had been done in the 60s finally came into play and was used. And it was used under the fiscal pressure of simply saying, you're not getting any more money. In fact, you're even going to get less. What are you going to do about it? Oh, well, in that case, we'll do something clever. And they did. And that was a major advantage. The downside is that Canadians have never been as confident in their healthcare system again, that the process of cost cutting really lost a lot of public support for the system. But it also not only saved money, but made for better medical care. And the public has very little idea about that. And that's unfortunate. That's extremely unfortunate. But that's the sort of thing we now have to think about with respect to, say, diagnostic imaging, with respect to the inflation of alternative payment programs for physicians. A whole bunch of areas where we can go now looking for those public solutions. And what I'm saying is two things, I guess. They are there, and the system has not been blowing up fiscally in the past. In the future, yes, the rate of impact of aging will increase. Sure, there is such a thing as a baby boom. That is going to happen. But demographic factors don't work overnight. They work very slowly. They work like glaciers. They reshape the landscape, but they don't do it in 1 year or in 5 years. So you have lots of time to react and to adapt. And most of the European systems operate with populations that are much older than our present population. So there's no particular reason why our system has to blow up. There's heaven. We can adapt to that. So there's an awful lot of that. You know, the demographic stuff is a lot of panic mongering. It's true that the population will have fewer working age people in it, a lower proportion. So yes, maintaining output in Canada will be perhaps more difficult with a population that has a much larger proportion of older people. So the people who talk about that are not wrong. On the other hand, they've been worrying about productivity in Canada for the last 20 years. So whatever it is that's inhibiting productivity growth in Canada hasn't been aging of the population in the past. And if we could figure out what was wrong with productivity growth now, that would eliminate much of the issue of the aging population. Yeah, you know, it's not a matter of, oh my God, we've got a problem coming up, we've got to scrap or modify or water down, cut back the public healthcare system. That brings me back to where I started. The people who are saying that now are the people who have always said that. And they've said it for very good reasons. That if you are in the upper income brackets, you don't want to have your taxes increased. You don't want to have your taxes even what they are now. You want to have them cut. They've been cut. Move the costs back onto the users. That moves it down the income spectrum and off me and onto them. And basically, again, the TD report is quite helpful because that's exactly what they suggest with this stuff about pre-funding drug expense. Nothing about cutting drug expense, as the Ontario government has done dramatically, but a lot about can we get more money for it, and can we get it through a form of taxation that will bear more heavily on people at lower incomes? Because that's what private insurance or any kind of insurance system does. It doesn't make your contributions proportional to your income. It makes them proportional to your risk status. And even if it's a public system that says we won't risk rate people, we'll just charge everybody the same premium, you're paying the same premium no matter what income bracket you're in. Now, some of these schemes say, well, we'll make the premium related to your tax bracket. Well, that's fine, but your tax bracket tops out at about a little over $100,000. So for the people who are making a lot more than that, they're home and dry with any system that involves fixed premiums that are related to your tax bracket. So this Kirby Commission recommended the same thing with the same issue. You know, this is a boon for people at the very highest income brackets. We did the same thing in BC with the Fair Pharmacare program. Again, you know, so all of these gimmicks for finding more money for the system through other forms of taxation or user charges or whatever, you look at them, they're all regressive. They all come down to hitting people at the lower income brackets harder, as well as, of course, taxing the sick. That's just inherent in their very nature. So you say, why would anybody want to do that? Oh, well, the system's unsustainable, it's falling apart. Well, it's not. It's not. It's going to require difficult, careful, thoughtful management in the future rather, as it has in the past. Those will not be difficult. Those will not be easy problems. I don't envy the position of provincial governments. But the point is that they are possible. They are possible, and the Ontario government has just demonstrated that, you know, on the front page. So that's where I'd like to stop, I think. Thank you.
Thank you very much, Bob. So we do have time for a few questions. I know we have to have some of you off.